I really feel very happy and humbled to be amongst my endocrine colleagues from India. It's truly a really great pleasure to be meeting with all of you. And thank you, Dr. Joshi, Dr. Bantwal, Dr. Jindal, and Dr. Sahai for this privilege. And thyroid has been my area of interest since I started my residency and fellowship. And I mostly work with thyroid cancer, but you know, any area of thyroid is always challenge. Any challenge in areas of thyroid always is a great experience. So I'll be talking about the topic provided to me, that was thyroid peroxidase antibody estimation in hypothyroidism and beyond. So we know that the autoimmune thyroid disease encompassing Hashimoto's thyroiditis, Graves' disease, postpartum thyroiditis, the prevalence is approximately 5%. And over the years, we have had susceptibility genes identified, including the HLA-DR subtypes and the non-MHC genes, the immune regulatory genes, including CD40, CTLA4, and other genes, as well as thyroid-specific genes like thyroglobulin and TSH receptor genes. The environmental triggers with epigenetic modification have, in the presence of these susceptibility genes, lead to breakdown of immune tolerance and the autoimmune thyroid disease. I'll be talking a little bit about iodine in one of the slides upcoming. So with the autoimmune thyroid disease prevalence, there comes a quest to find antibodies that will reliably detect and predict autoimmune thyroid disease. So anti-thyroid peroxidase antibodies, as you all are familiar with, is widely in use in the quest for finding a detection as well as prediction. So as we know, anti-thyroid antibody, peroxidase antibodies against the thyroid peroxidase, which is, a poorly glycosylated membrane-bound enzyme, which is involved in the oxidation of iodine and in thyroid hormone synthesis. In most of the older literature before 1985, they have used microsomal antibodies. And since then, we have been able to isolate the more specific thyroid peroxidase antibody. It's the most sensitive biomarker for Hashimoto's thyroiditis and detectable in 90 to 95% of Hashimoto's thyroiditis patients, approximately 80% of Graves' disease patients, and up to 10% of non-Hash autoimmune thyroid disease patients in healthy population. There has been reports of a good correlation between the presence and the severity of lymphocytic infiltration of the thyroid gland with the titers of antiperoxidase antibodies. Although this has been an area of a bit of controversy. If the serum is only positive for one autoantibody, it's more likely to be a peroxidase antibody than thyroglobulin antibody. And as we know, in most, as in all autoimmune thyroid disease, most of the prevalence is more in females than in males. And if you notice in this graph over here, Hashimoto's thyroid is approximately the prevalence of peroxidase antibodies is approximately 95% here when compared to relatives of patients who have at least one, these are all euthyroid females with at least one relative with autoimmune thyroid disease. And in them, the prevalence of antiperoxidase antibodies is also quite high when compared to, these are healthy blood donors. When compared to them, the prevalence of peroxidase titers are much, much higher. So this is from the NHANES 3 data, which is the population percentage of the US population who have positive peroxidase antibodies. And this is described by age, gender, and the sex. So if you notice here, the peroxidase antibody titers, when in all races, all ethnic groups, the titers tend to increase as the age increases, similarly in females. And as we notice, females have a much higher prevalence compared to the males. And this also holds true in the disease-free population, where females have a higher prevalence of peroxidase antibodies compared to males. And it holds true for the same age increasing with age. And what we see here is in the non-Hispanic Black population, the African American population, um, the prevalence of peroxidase antibody titers are actually lower compared to the non-Black, the Hispanic or non-Black population, as in other races. It's much lower than other races. So what I'm trying to show here is the peroxidase concentration, antibody concentration increases with age. It's more prevalent in women and less prevalent in certain ethnic groups. And this is, I looked at this study from Dr. Unikrishnan's group. And as you see here, these are big cities in India, and this is an iodine sufficient population. And even the titers, the antibody positivity is quite high across these cities. And this is an iodine sufficient population. So there has been some studies reporting, iodine is supposed to increase the immunogenicity and hence an increased in thyroid peroxidase antibody positivity in this population. So what defines a TPO or thyroid peroxidase antibody positivity? At this time, we do not have recommendations for, what's the accurate definition of TPO positivity. So most of us just use the cutoffs provided by the assay manufacturers. And these cutoffs are derived based on the population reference range, the sensitivity of the assay, and the risk of Hashimoto's thyroiditis. So a wide range of cutoff values are reported across literature. It's from 0.25 international units to 200 international units have been used as an upper limit of TPO positivity. So normal reference ranges have usually been set up so that a large majority of patients with autoimmune thyroid disease, they test positive. So going back to one of the landmark studies, the vikram study, and this is a landmark study which looked at a great population, almost 3,000 patients from Great Britain from 1970s, and they looked at the thyroid autoantibodies in these patients. This is a follow-up study from the initial vikram survey, 20 years follow-up study. And this study looked at the vikram population and what is the natural history of antibodies. So looking at the first survey and the second survey 20 years later, this is what they see is that most of the patients, about 8%, if you look at women less than 45, 8% had positive thyroid antibodies. These antibodies include peroxidase and thyroglobulin antibodies. However, majority of them had a peroxidase antibody titer positive. And if you see, had 8% at the time of the first survey had positive antibodies. And then 20 years later, the antibody titers are almost 3 times higher, and it's 24%. So, and the same thing that we have seen is that as they get older, they tend to have higher antithyroid antibodies. And this holds true, and they tend to hold on to those antibodies as they get older. Only a small percentage of people lost their antibody titers at 20 years, 0.8 to 3%, but on average at 2% total. So majority of them, 26% of the people over 20 years had continued to have high titer positive antithyroid antibodies. So the natural history of these antibodies is that they tend to stay. So what are the odds of developing hypothyroidism? If a euthyroid female has positive antibodies, then what is her odds of developing hypothyroidism over time? So if the TSH is raised, which means that the TSH is just over the upper limit of normal, regardless of the antibody status, the odds are almost 14. Whereas if they have antibody positive, regardless of the TSH titer, that's almost similar. And what I want you to see is that a TSH alone or antibody alone, they tend to have similar risk of odds of developing hypothyroidism. And when combined with elevated TSH, these are subclinical hypothyroid patients with antibodies combined, their odds of developing hypothyroidism jumps up to 38. And this vikram follow-up group, they did a probability analysis of patients with TSH levels on the x-axis, the logit probability on the y, and the probability on this axis here, with using antibody positive and negative patients. So as you can see here, what stands out in this graph is beyond a TSH, at a TSH of 2 and above, there is a distinct shift in probability of developing hypothyroidism, irrespective of antibody titers. And when you look at the TSH, if let's say the TSH goes up from 2 to maybe doubles to 5, and at this time, if you notice, antibody positive population, the probability of developing hypothyroidism, if it was here at 1%, it jumps up to almost 38, 40% here. So presence of antibody positivity, in addition to a higher TSH, does increase the probability of hypothyroidism over time. Again, looking at a slightly different way of looking at the same data. So it's like, these are about 800 euthyroid females, healthy females, who have a positive family history of autoimmune thyroid disease, and they were checked for peroxidase antibody titers. And these females have been grouped based on their antibody titers. So as you see here, euthyroid females with the family history of autoimmune thyroid disease and higher titers of peroxidase antibody titers tend to have higher TSH level at baseline. So the higher the antibody titers, they are more likely to develop hypothyroidism in future, and they tend to have a slightly higher TSH level, even though they are euthyroid at this time. So what is if the patient have subclinical hypothyroidism, what's the rate of progression to hypothyroidism when they have positive antibody titers or when they have elevated TSH levels? So if you notice, there is a distinct difference between these two graphs here. And those with TSH levels higher than 6 and to 12, they do progress from subclinical to overt hypothyroidism. And the ones with higher TSH level more than 12, they tend to progress much quicker to overt hypothyroidism. And similarly, the presence of antibody microsomal antibodies or peroxidase antibodies, um, also shows a separation in the graph early on. So which means that within even less than 2.5 years, there is a split in the graph, and it shows that they are more likely to progress to overt hypothyroidism. Moving on to another entity, which is the postpartum thyroiditis. So the incidence of postpartum thyroiditis is, in the reported literature is widely variable between 1.1 to 18%. And the reason it's so variable is because, it depends on the time of pregnancy that the antibodies were measured, the screening tools used, antibody titers, iodine status, all of that. So the incidence is variable, but we know about the risk of the role of peroxidase antibodies and the association with postpartum thyroiditis. So we'll be looking at just a few slides on the role of peroxidase antibodies in identifying women at risk of postpartum thyroiditis and predicting postpartum thyroiditis in subsequent pregnancies. So the best time to check peroxidase titers are in the first trimester. Approximately 10% of women have positive thyroid and peroxidase antibodies at 16 weeks of gestation. And out of these, almost 50%, up to 50%, will, with these positive antibodies, will go on to develop postpartum thyroiditis. And those with higher titers are at increased risk of developing postpartum thyroiditis. When they have positive antibodies, as well as the increased hypoechogenicity of the thyroid gland on ultrasound, these populations have a higher risk of permanent hypothyroidism. And postpartum thyroiditis is often linked to depression. It's not the psychotic depression, but it's the non-psychotic depression, which is more common in these women with positive antithyroid antibodies. Um, and the risk of recurrent postpartum thyroiditis after a subsequent pregnancy is almost 70%, whereas those who have just positive titers of peroxidase antibodies but not hypothyroid, the risk of recurrent thyroiditis drops to almost 25%. Now, a quick look at peroxidase antibodies in non-thyroidal conditions, and pregnancy, infertility, and live birth rate. These have been one of the most often consultations that we have received for these antibodies in females. So what happens during pregnancy is this line indicates the women with negative antibodies, peroxidase, and this line represents women during pregnancy but have positive peroxidase antibodies. What we see here is throughout the time of the pregnancy, throughout the weeks of gestation, women with positive peroxidase antibodies tend to have TSH levels that are higher than women without antibodies. And these TSH levels do progress during gestation and stay higher than those with negative antibody titers. There is a statistically significant difference at all gestational age. So euthyroid women with peroxidase antibodies, and as we saw, they have a higher TSH level, and all of these studies have looked at and found similarly higher TSH levels in antibody positive women. And the difference is like 0.8, almost a very small difference, but it is statistically significant difference between these two group of women. So is it all because it's only a 0.8 plus minus 0.58? So it's a very small change in TSH. So the question is it TSH that's the reason for this change? So there is an increase in miscarriage rate. What all of these is a meta-analysis looking at several studies looking at the rate of abortion or miscarriage in antibody positive euthyroid women compared to antibody negative euthyroid women. And as you can see, the miscarriage rate is much higher in these group of women with positive antibodies, but they are euthyroid compared to antibody negative women. So the question was, as we saw, TSH is higher in this group. They are antibody positive, even though it's a small TSH change. Is it all because of TSH that we see an increased miscarriage rate? So Negro and his colleagues, they tried to eliminate this TSH effect by treating all women with levothyroxine. Um, all women with thyroid peroxidase antibody positive with levothyroxine. So these are euthyroid women, but peroxidase positive. They were treated with levothyroxine, and what they showed is a miscarriage rate is all in these women who were treated. It drops to is almost same as antibody negative women, and you see the difference of almost, this is 14% versus almost 2 point something percent between those treated and untreated groups. And similarly, the preterm delivery rate also is comparable to antibody negative women when treated with levothyroxine. So essentially suggesting that, it's TSH that's causing, that's responsible for this difference, because it drops the pregnancy complication similar to antibody negative patients. However, this doesn't prove causality. And what stood out in this study, however, was most of the miscarriage was reported around 11 weeks of gestation, whereas, and all of these, the average time that these women were introduced to levothyroxine was about 8.5 weeks. So not sure if that created that much of an impact, but this is something interesting. So most of the literature proven on thyroid autoimmunity and infertility is in women who are planning for assisted reproductive technology for infertility. So we have seen that there is an increased prevalence of autoimmune thyroid disease in women attending infertility clinics. A lot of it has been attributed to endometriosis, but what has stood out is that treating the women who have peroxidase positive titers, they had the versus negative titers, there was no difference in outcomes when it was related to the oocytes retrieved, the rate of fertilization, rate of implantation, or the clinical pregnancy rate. And what did stand out was there was a decrease in live birth rate in women who had positive antibody titers. So the current recommendation is to treat euthyroid women with positive antibody titers and planning to undergo assisted reproductive treatment technology. And these are the recommendations that there is insufficient evidence to recommend for or against levothyroxine therapy in thyroid peroxidase positive euthyroid women during pregnancy. So these are women with TSH less than 2.5. And euthyroid women not receiving levothyroxine plus antibodies, they require close monitoring for hypothyroidism during pregnancy. And then women who have had previous pregnancy losses with positive antibodies, you may consider levothyroxine treatment. I'll just spend a few minutes talking about some ill-defined associations of peroxidase antibodies and other non-thyroidal diseases. So these are not so established, but they've been talked about a lot. Hashimotosencephalopathy, I'm sure you all have been consulted in such a difficult consultation. And vestibular dysfunction, these are idiopathic vestibular dysfunction identified by abnormal testing, and they have been linked to antiperoxidase antibodies, but we don't know the pathogenic mechanism. Similarly, chronic idiopathic urticaria and peroxidase antibodies, the consult is from usually the allergy immunology clinics. And actually, in my experience, we have had a few patients with very bad hives and positive peroxidase antibodies. I'm not sure. There is just some case reports. We don't have big studies, but people who underwent thyroidectomy and they actually had resolution of their hives. I have a couple of such patients, but I don't know the data on this because these are all case reports. And then lately, a lot about immunotherapy in oncology and autoimmune thyroid disease, immune reconstitution, as in HIV patients after starting the highly active antiretroviral treatments, and some literature on peroxidase titers having a protective effect in breast cancer. I'll be just talking about two of these conditions here. So Hashimotosencephalopathy, as you know, it's a subacute encephalopathy. The neuroimaging is usually negative. They have high titers of peroxidase antibodies, usually euthyroid, and it's a diagnosis of exclusion. And at this time, we do not know the pathogenetic mechanism. Lot of suggestions like, the peroxidase, they lead to astrocyte damage, they lead to neuronal synaptic losses, but overall they respond to steroids. The peroxidase is used as a serological marker, but what we know for sure is actually this disease is more, the alpha enolase antibodies are more positive than peroxidase titers. So again, there's a lot of disagreement between endocrinologists and neurologists about this disease. And one of the reason being, the frequency of antiperoxidase antibodies in these population of neurologic disorders, as you can see, they all have a high titer of, frequency of peroxidase antibodies. These are possible autoimmune encephalopathy. These are enolase positive encephalopathy. This is multiple sclerosis, and this is the cryptogenic new onset status epilepticus, and these are the neuromyelitis spectrum diseases. So they all have the frequency of peroxidase antibodies, they are widely distributed, and hence we came across, we coined this term as steroid responsive encephalopathy associated with autoimmune thyroiditis. Now, immune therapy, that's the new kid in the block, and almost we started with melanoma, and now immune therapies are used in lots of other oncologic diagnoses, and we are seeing a lot of thyroid problems, autoimmunity, with the introduction of immune therapy. And this group, Osorio and his group, what they found was patients with those with positive thyroid dysfunction, almost 80% had positive thyroid antibodies. And these antibodies could be, they were either peroxidase antibody titers, or they were TSH receptor antibodies. So, but this has not been duplicated in other studies. However, most of the studies on immune therapy and antibodies, they're very small studies. So, the number of subjects, as you can see, is very small. We did publish a few, and even we didn't consistently see the presence of antibody titers. So at this time, this is again a controversial area. So thank you very much for your attention. These are tulips from Michigan.